Hello everyone. Today, I would like to talk about tumor immunology. How do cancers develop? How do cancer cells evade our immune system? And how do we approach immunologically to fight against cancer cells? Cancer is a devastating disease, and it accounts for about 20% of deaths in the industrialized countries. According to the Cancer Facts and Figures 2011, published by American Cancer Society, in 2011, approximately 571,950 Americans were expected to die of cancer. That is more than 1,500 people a day. Cancer is the second most common cause of death in the United States, exceeded only by heart disease. In the US, cancer accounts for nearly 1 of every 4 deaths. Cancer cells are very similar to normal cells, and the immune system seems unable to attack them effectively. In treating cancer, physicians resort to surgery, radiation, and chemotherapy, sometimes referred to as strategies of slash, burn, and poison. How do cancer cells develop? To maintain the human body, our body keeps on replacing old, damaged cells with a new cell to repair tissue. This is done by cell division, replication of the cell. During their lifetime, 10 to the 16th times of cell divisions occur in a human body. An essential preparation for cell division is DNA replication, and this is a highly precise mechanism protected by multiple systems of proofreading mechanisms to correct mistakes. Although it is rare, errors are still made, and this is called mutation. They include the substitution, insertion, and deletion of nucleotides, recombination between different members of the gene family, and chromosomal rearrangements. There are 2 main classes of gene that, if mutated or misexpressed, contribute to malignant transformation. Proto-oncogenes are genes that normally contribute positively to the initiation and execution of cell division. If this is mutated, then this will be called oncogenes. The second class of genes involved in cellular transformation are called tumor suppressor genes, because they encode proteins that prevent the unwanted proliferation of mutant cells. A typical tumor suppressor gene is that for the protein p53. This protein is expressed in response to DNA damage and causes the damaged cell to die by apoptosis. Loss of the p53 gene or mutations that interfere with its protective function are the most frequent mutation present in human cancers. More than half of cases of human cancer have a mutation in p53. The control of cell division never depends on the function of just one protein, and a cell cannot become cancerous by mutation in just one gene. For a cell to give rise to a cancer, it must first accumulate multiple mutations which was not repaired, and these must occur in genes concerned with the control of cell multiplication and cell survival. However, this may happen resulting in malignant transformation of the cell. So, you start with your own normal epithelial cell. When one of the tumor suppressor gene, APC, is lost, excessive epithelial proliferation will occur. Once oncogene RAS is activated, this will start to form small benign tumor. By loss of tumor suppressor gene DCC, this will then become a large tumor. Then, if you lose P53 tumor suppressor gene, tumor becomes invasive and it accumulates mutation rapidly, gaining ability to metastasis to another part of the body. This sequence all starts from one cell of your own. All of a sudden, it will decide to go its own way, like saying, I have an idea. Why not create a whole bunch of my clones and take over this body? Or, after forming a decent-sized tumor, one cell will go through enough mutation and say, well, let's see if there's anywhere else I can go to. And metastasis. Certain viruses are also associated with some 15% of human cancers. They are known as oncogenic viruses. Human oncogenic viruses typically set up chronic infections in a cell, producing novel virally encoded proteins that override or interfere with the cell's normal mechanisms for regulating cell division. Infected cells, therefore, start to proliferate. Papillomaviruses are associated with uterine cervix cancer. Hepatitis B virus are associated with hepatocellular carcinoma. Epstein-Barr virus are associated with Burkitt's lymphoma and nasopharyngeal carcinoma. Human T-cell leukemia virus type 1 are associated with adult T-cell leukemia or lymphoma. And HIV-1 and human herpes virus 8 are associated with Kaposi's sarcoma. Okay, that was about the development of cancer cells. By the way, when you take your dog for a walk, make sure you don't make the same mistakes that he made. Now, let's move on to how cancer cells evade from immune cells. Cancer cells are scary and clever. They are often asymptomatic until they are hard to treat. They stay low as they can, growing in numbers, until they are ready to take over the body. If something abnormal is going on inside of a cell, especially in its DNA, it should present on HLA class 1. That's what HLA class 1 is for, presenting part of its DNA or protein for natural killer cells and T cells, so they can detect abnormal cells and terminate them. Self-proteins are routinely digested by proteasomes within the cell's cytosol, and peptides derived from them are delivered to the endoplasmic reticulum, where they can bind to HLA class 1 molecules and be delivered to the cell surface. There are countless immune cells circulating your body, patrolling like a watchdog. If they find something abnormal going on, they bark and let others know, or they attack. How cancer cells keep on replicating itself without being recognized by human protective system? The immune response to an infectious disease is started by inflammation produced at the initial site of infection. This makes innate immune mechanisms available within hours after the start of infection, and adaptive immune responses are fully operational within 2 weeks. In comparison, the malignant transformation of a cell that marks the start of a cancer goes unnoticed by the body. For years, the growth of a cancer might cause no damage of the sort that would trigger inflammation and immune response. When tumors arise in a tissue, a number of immune cells can recognize and eliminate them. However, variant tumor cells arise that are more resistant to being killed. Over time, a variety of different tumor variants develop. And eventually, one variant may escape the killing mechanism or recruit regulatory cells to protect it and so spread unchallenged. This process is called immunoediting because it shapes the properties of the tumor cells that survive. This will create the super macho tumor cells, which is now able to grow unimpeded and become clinically detectable. One way in which tumor cells can evade recognition by immune cells, especially by cytotoxic T cell, is not to express the HLA class I molecule that presents tumor antigen to the T cell. Between 1/3 and 1/2 of human tumors have defective expression of one or more of their HLA class I allotypes. What this means is that many patients have made a CD8 T cell response against their cancer, but that variant cells lacking particular HLA class I allotypes escaped the immune response and expanded to keep the cancer going. It's like they are wearing a mask and hiding their personality. Many human cancers of epithelial cells exploit the expression of MIC to their own advantage. MIC proteins are structurally related to MHC class I molecules. They are ligands for the activating NKG2D receptor, which is expressed on all natural killer cells, gamma delta T cells, and cytotoxic T cells. Expression of MIC by epithelial cells, therefore, facilitates their attack by these 3 types of lymphocyte. MIC proteins are expressed on the cell surface of epithelial cells when infected or stressed in other ways. Cancer cells use proteases to cleave MIC from the cell surface, producing a soluble form that binds to the NKG2D receptor of infiltrating lymphocytes. Binding of MIC to NKG2D induces receptor-mediated endocytosis that removes NKG2D from the surface and speeds its degradation. By removing MIC from their own surfaces and removing NKG2D from lymphocyte surfaces, the tumor cells evade attack by natural killer cells, gamma delta T cells, and cytotoxic T cells. Tumors often secrete molecules such as TGF-beta that suppress immune responses directly, or can recruit regulatory T cells that can themselves secrete immunosuppressive cytokines. Tumor cells can also secrete molecules such as collagen that form a physical barrier around the tumor, preventing lymphocyte access, just like bacteria forming biofilm. These are the examples of how tumor cells evade from our immune systems. By the time that the cancer's growth is damaging tissue and raising the alarm of inflammation, the tumor load is usually so great that the immune system is likely to be overwhelmed. It does not mean that our immune system is not fighting against cancer cells. By the time they are recognizable, causing inflammation, they are too big to fight with. Cancer cells lay low until they grow in size and gain enough numbers to overwhelm your immune system. It is hard to recognize because it was one of your own in the first place. They mutate, change, and turn against yourself. Once it is big enough to be recognized, it is usually too late. Well, you gotta be careful on what you pick on, because you might put yourself in a big trouble. Now, moving on to the final part of this presentation, using the immune response to attack tumors. We reviewed how cancer cells evade from immune cells. How can we overcome their tactics and strengthen or manipulate our immune system to be able to eliminate cancer cells? When alloreactive T cells in the graft help to rid the patient of residual leukemia cells, it is called a graft versus leukemia effect, or a graft versus tumor effect. A current movement in hematopoietic stem cell transplantation is to use new protocols that seek to promote the GVL reaction and to place less emphasis on using chemotherapy and irradiation to eliminate the tumor. This allows less severe conditioning regimens to be used that do not completely disable the patient's hematopoietic system. After treatment, the patient is less severely immunocompromised and recovers more quickly. One approach to the manipulation of a GVL effect is to give patients transfusions of donor lymphocyte or T cells after they receive the hematopoietic stem cell graft. Such donor lymphocyte transfusions are given at a time when the inflammation caused by the conditioning regimen has subsided and the likelihood of severe GVHD is diminished. As mentioned in the earlier slide, several types of cancer are caused by chronic viral infection. HPV-16 is a known cause of most types of cervical cancer, and the virus can be detected in 50% of cervical tumors. HBV infection is known oncogenic virus for hepatocellular carcinoma. Vaccination for these viruses will reduce the risk of developing certain cancer for individuals. One approach is called adoptive T cell therapy. This therapy involves the ex vivo expansion of tumor-specific T cells to large numbers and the infusion of these T cells into patients. Cells are expanded in vitro by culture with interleukin-2, anti-CD3 antibodies, and allogenic antigen-presenting cells which provide a co-stimulatory signal. Adoptive T-cell therapy is more effective if the patient is immunosuppressed before treatment, and its effects are enhanced by the systemic administration of interleukin-2. T-cells directed at malignancies expressing EBV antigens can also be expanded in an antigen-specific manner by using EBV-transformed B lymphoblastoid cell lines from the patient. Another approach that has excited much interest is to transfer tumor-specific T-cell receptor genes using retroviral vectors into patients' T-cells before re-infusion. This can have long-lasting effects as a result of the ability of T-cells to become memory cells, and there is no requirement for histocompatibility as the transfused cells are derived from the patient. The genes encoding the alpha and beta chains of a specific T-cell receptor are cloned into a retroviral vector. The vector is transferred into a special packaging cell line which secretes the vector DNA inside viral particles. The viral particles carrying the specific TCR alpha and beta chain genes infect other T cells and cause them to express a new TCR. The transfused T cells will now recognize the same antigen and can be stimulated to proliferate. Heat shock proteins are soluble intracellular chaperone proteins that organize the folding, assembly, and degradation of cellular proteins. They were first discovered as proteins that were produced in cells in response to the stress of raised temperature, hence the name heat shock. Heat shock proteins bind peptides and disorganized parts of proteins in a manner akin to MHC molecules, but they bind with more promiscuous specificity. Animal models of cancer vaccination have shown that immunization with heat shock proteins extracted from cancer cells produces a powerful anti-tumor response. The heat shock proteins bind and carry a potent cargo of protein and peptide tumor antigens. These they specifically deliver to dendritic cells for presentation to T cells. When taken up by dendritic cells, heat shock proteins can deliver tumor antigens directly to the antigen processing machinery of the dendritic cell. They may also activate dendritic cells through signaling receptors. Because of these functions, heat shock proteins have been described as natural adjuvants of the human immune system. That cancers are rarely terminated by the immune system is largely because of failures in starting the response early enough and making it strong enough. Manipulation of dendritic cells and heat shock proteins might help to overcome these limitations. The basic idea is to isolate dendritic cells from a patient's blood and load them with heat shock proteins isolated from the patient's tumor or with defined tumor antigens. Thus charged, the dendritic cells will be replaced in the patient's circulation, where they will home to the secondary lymphoid tissues and initiate a tumor-specific immune response. So, that concludes this presentation about tumor immunology. I'd like to finish my presentation with one of my favorite jokes. Theory is when you know everything but nothing works. Practice is when everything works, but no one knows why. In our lab, theory and practice are combined. Nothing works, and no one knows why. Thank you for listening to my presentation.